My name's Andy Thomas. I'm a paramedic. I work clinically on the critical care ambulance response unit within the North East Ambulance Service region. And I also have a few other things that are worth declaring at this stage in a presentation. I do chair the local basic scheme in the North East. I'm also the chair of the Paramedic Advisory Group for the Faculty of Pre-Hospital Care. I sit on their training standards boards, and I also chair the Regional Faculty of Pre-Hospital Care Group for the North East region as well. And I'm a Paramedic Council member on Trauma Care UK. What I'm going to talk to you about today is about surgical airways, and this is not from any of those roles. Until 8 months ago, I was a serving member of the Royal Air Force, in which I did multiple deployments to Afghanistan on the Medical Emergency Response Team helicopter. The last 2 years of my job was as an academic research fellow at James Cook Hospital, and that's when sort of my taste for research and looking at data and stuff got into different things, and this is just one of those things that me and some of my fine colleagues have looked into. Speaking of which, obviously it's important to give people credit for the excellent work they do. I'm just speaking tonight, but there's many other people involved, and then as you can see the list of people there, in particular Warrant Officer Tony Kyle is sort of the lead publisher on this piece of work, and we've got a few of our consultant doctors there, and also Vicky was one of our statisticians. So without further ado, let's get on to what we're here to talk about this evening. The first thing I'd say is surgical airway placement is uncommon in normal UK civilian practice, and we're going to look at how this might potentially affect future paramedic practice. However, it is rare. However, when you look at some of the studies from US military and what they've done of late, to put this presentation into context, they've had 3 or 4 studies now in which their success rate on the battlefield in certain surgical airways is anywhere between 50 and 82%. One study as well showed that they had a 0% success rate. However, that was from a previous conflict in Iraq, and therefore I've not overly emphasized that. But yeah, from 50 to 82% success rates, which obviously is a bit hit and miss, but there's many reasons for that. It is important to note that from a battlefield, so the context of when this research was done and why it was important to the military at the time, is that airway compromise accounts for up to 2% of combat deaths and is the 3rd leading cause of potential preventable death in the combat zone. So when people are getting blown up or shot, airway compromise is that 3rd leading cause of death. So 2% of combat casualties are dying as a result of airway compromise, and therefore it's an important area that we need to address. So we kind of went on a bit of a journey with this one. It was one of the first sort of studies I did where I went from start to finish, as I say, with myself and Warrant Officer Tony Kyle. And we first of all had to seek approval for the data collection. And the reason we thought about doing this is we'd seen some of those American publications, and the 82% one was only a recent one, which was done at the end of the conflict and was mainly helicopter based. However, some of the battlefield data that the Americans were producing, as I say, from Iraq and Afghanistan, showed very low success rates, which was very different from what we'd experienced on board the MERT, where when we were collecting the guys off the battlefield from the combat medics on the ground, from the very junior doctors who'd been treating these guys at point of injury, we felt there was a very high success rate of surgical airways from our experience when we're looking at British medics on the ground doing the procedure, and therefore we thought we'd look at the data to see actually what was true and what wasn't. So we got approval from RCDM, which is the Royal Centre of Defence Medicine, where in the research park down there, which allowed us to carry out this service evaluation. It was a retrospective analysis looking at all patients in between 2006, is when the conflict began, and 2014, obviously towards the end. We used the Joint Theatre Trauma Register, and we basically put a request in, and they through the data collection they do send you a big list of things to look at, and we hand trawled all the notes. So, and I'll come on to the details in a bit further down the presentation, but we started off with 203 patients, and the data only presents 86, and there's multiple reasons for that. Obviously, we went down to hand trawl the notes in the end because we felt some of the data collection wasn't accurate on the computer printout we'd been given. So we went and did a deep dive on all the hand notes, which is down in place down in the south, and we spent a couple of days there raking through computer systems with scanned copies of notes and actually hand trawling some of them. It wasn't easy, and it definitely is harder than you think. For those who are not into research and data collection, this is the boring bit of the presentation, I'm afraid. It is hard graft, but certainly it was a huge learning experience for me certainly not to trust all the data you're initially presented with without going to check it properly for yourself. So the data I will be presenting tonight is very robustly being looked at. So what was the inclusion criteria? We have to have inclusion exclusion criteria. And for us on this one, the inclusion criteria is quite simple. All patients who have had a surgical airway performed by UK forces. So that means if, for example, it was American soldiers that put the surgical airway in or whatever, we would exclude them out of our data collection. We were purely looking at the performance of UK medical personnel. And then we had some ways of confirming this. As I say, we've explained the hand trawl, we've explained the what we call the JIT, the Joint Theatre Trauma Register. And basically myself and at the time, Tony, we went through and did a two-phase technique. So we'd find the patient who had been identified as potentially having the surgical airway from the computer search, pull up the notes, and we'd both independently verify what had gone on with that patient. We used things like, was the procedure recorded? Was there any record of end-tidal CO2 being produced? Was there any record of it being successful? Because there was a box they would tick. We would also look at, did the patient's symptoms improve? So if they had low saturations prior to the procedure, did that improve once the procedure had been conducted? And in some cases, we went and looked at the post-mortem results and see if the correct placement confirmed that post-mortem if the patient sadly died. So very thorough look at this. We inputted all the data into SPSS and used statistical analysis. We did use an independent statistician. I ran the data first myself because I can do a little bit on SPSS, but then we go an independent person to fully check that data, which again is, I think, if you're going to do these kind of things, it's good practice just to make sure you're not influencing the results you're getting. And the primary outcome was simple: was that surgical airway correctly placed? We were pleased with the results. In simple terms, we'll go on to the depths and the details shortly, but we had a 92% success rate, and almost all of these surgical airways were put in by medics or very junior doctors on the ground in the most hostile of environments. And I was pretty proud of those guys on the ground, the combat medics, the Navy MAs, etc., and the GDMOs, the junior doctors, who'd obviously managed to achieve such a success rate. It was what we suspected, because we felt from some of the American data that we were performing better, but it highlighted an area of why and why are we performing better, and we'll come on to that again shortly. So the results, 88 patients met the inclusion criteria. That's actually 86 when we move further down, because we excluded 2 that resulted when we dug a bit deeper. We're done in the emergency department. The mean patient age was 25 years. And that had a standard deviation of 5, so a very fit, young fighting population in general. The median injury severity score was 62.5 with an interquartile range of 42. So what, if you're not into your stats and stuff, what basically that's saying is injury severity score ranges from 0 to 75, 75 being completely unsurvivable. Anything above 15 is classed as major trauma. So these are very high injury severity scores. So the patients we're looking at are horrifically injured. As I say, 79 was successful to be found, and 7 so we're looking at about an 8% failure rate there. And we were really strict on this criteria. So if we couldn't prove the device worked, we counted as a failure. So devices may have been correctly inserted, but for whatever reason there was an air leak because the cuff failed. We counted that as a fail, whether it's equipment or individuals, just to be very rigid. I think the real message that I took away a bit of heart from this one was that 21 patients, 26% survived to hospital discharge. So as a result of having a completely compromised airway, and undoubtedly without the procedure, death would have occurred. 26% of these patients survived to hospital discharge, and that's great credit to the guys on the ground. 90% of the surgical airways were performed either by medics on the ground or GDMOs, as I've already said, at point of wound and or what we call the roll one dressing station. So the fob, so a tiny little base where guys might have been attacked or pulled the casualty back to. And these are people, junior doctors, CT1s, maybe who are not on their training pathways yet, and as part of their Army duties or their Navy duties, Air Force duties, they go out to these locations and provide a bit of medical support to the guys on the ground with the medics. So these are people who traditionally are not registered, so the medics aren't registered, and the doctors are very junior who wouldn't normally perform this procedure. 7% were conducted on the MERT, and there's two reasons for that. Is because of the advanced teams we had on board the helicopter, and often with the consultant-led care we were delivering, most patients would be able to have, if needed, an RSI, and therefore our need for surgical airways was a lot lower. And out of interest, 2% were done in the emergency department. So box plots, the reason that we've got box plots here is the data was non-parametric, which means it doesn't sit in a nice bell-shaped curve, and therefore you have to analyze it a bit differently. And what the box on the left is basically telling us is comparing the patient's injury severity score to whether they survived. So as you can see on the right, those are patients who died. And if you look at the median line, which is the black line on the left, which I'll highlight with my mouse, and that line is very high here. This is the median because the data wasn't parametric, as I've said. So majority of these patients had ISSs of 75, and obviously they died as a result. And those patients who survived had much lower injury severity scores, and that doesn't take a rocket science to work that out. I wouldn't say this is interesting data, but the other thing I've just flashed up there, if the surgical airway was unsuccessful, I failed to perform, nobody survived. And as we know, the surgical airway is a latch cyst attempt, so I think we'd all expect that kind of data. When we're looking at this box plot here, you can see in front of you, we're looking at, on the left, success and survived. The middle one is the procedure was successful, but the patient still died, and the failure and the patient died. Obviously, these box plots are overlapping a little bit there, so that would suggest sort of the data is not massively statistically significant differences in them. However, it's very clinically significant. So if your surgical airway was successful, but you had that high injury severity score, then your chances of dying was drastically increased. And as you can see, the main bunch of the patients in the sort of three-quarter interquartile range here are well over 40, which are very high injury severity scores, and the survivors are more around the 20 ISS, which is something like, you know, to give it a civilian equivalent, somebody with a mid-shaft femur and a fractured humerus, for example. We had a little look at what GCS and versus survival had on there, and obviously we had some not recorded, but if your GCS was 3, then only 16% of these patients out of that specific group survived. So 75 patients presented at GCS 3, which was accounting for 80% of the patient population we were looking at, and they only had a 16% survival rate, which we're getting the point by now that high injury severity score, high injuries resulted in greater chance of dying. I think the only other thing to take away from this bit of the data is the 47 one is only one, the numbers are low, so it's hard to really ascertain anything statistically significant from there. But I think what is worth pointing out, some people with GCS 15 had surgical airways performed on them, and that may have been because of blasts, because of fragmentation, and there was airway compromise expected, or some flash burns, and the medics on the ground or the doctors on the ground may have done them preemptively before the patient potentially deteriorated. That's probably not something you would see much in civilian practice, but it accounts for what we saw in that environment. Let's have a chat over the study limitations, because I don't want to just go on about the data. I want to talk about what impact and stuff on civilian practice. So the quality of the Joint Trauma Theatre Register, we found it to be generally poor, and that's not a criticism to anybody who's doing that data collection, but you have to bear in mind there's lots of stages from the battlefield where data gets passed. So the guys on the ground may be writing on the back of their hand, maybe filling a scrap of paperwork that gets passed on, that gets lost. So data is limited in what comes through. The biggest problem we had was we had 203 originally. We only ended up with 86 patients. And I'm just going to flick through some of the publication that was just about to be published and chat you through. I haven't bothered putting the chart in, but chat you through why we couldn't. So 93 of those patients we couldn't find on the database. So when we went down to this place, we were looking on the database for these patients and we just couldn't find them on there. When we investigated further, The civilians that were inputting this data down at CHRL it only had the data put on the system until mid 2012, and then we had to go into a kind of warehousing and try and find the notes by hand. And you'd think they would be well organised, but they weren't necessarily the case. So that is a limiting factor. 12 patients had no record of the procedure in their notes. So for whatever reason, it had just been a slip of a finger, been miscoded as having a surgical airway, when in fact they had not received a surgical airway. 4 of the patients that were included in the initial search when we investigated, were done by US forces, so we excluded those. And 5 of the patients didn't have any surgery and did not have a surgical airway performed. They had a RSI performed, and they were ruled out. And obviously, were ruled 2 out because they were done in ED. The sample size is, some would argue, is small at 86 when I look at our final sample size. However, this is the biggest sample size of surgical airways in any military surgical airway research noted to date. So from that point of view, it's a good quality sample size. Another limitation, it was retrospective, not prospective. So we were looking back on it, and that is always a limitation of any research. And as I've already explained, battlefield information can have gaps in it. So, what's the impact of this on practice? What do we need to change for both a military point of view, and then further down the line, what impact will this have on civilian practice? And first of all, I think it's important to look at the difference of the 2 studies. So US studies show ranges. Obviously, there's that one study with 100% failure rate, but generally 50 to 82. And by the latter study, I think the US forces had learned some of their lessons and were starting to adjust their methods and so on and so forth, and that really helped in their success, up to 82%. But over the whole conflict, ours was pretty consistent. We didn't suddenly get better at the end. Throughout the whole conflict, the data was pretty high, and as I say, we had that 92% success rate. So why is that? Well, when you look at some of the US data, when you read their publications, one of them states that within the study, they noticed that through all the different units, the different services and the different areas of the service, that units deploying between them were carrying 11 different surgical airway kits. So there was no standardization. And I'm going to use the term bandwidth. If you look at the American combat medics, they're often also trained to intubate on the ground. And one of my theories behind this is, as they were failing to intubate, failing to ventilate, they got very task focused, and then the time they pulled the surgical airway kit out, they'd already really used up a lot of their bandwidth at this stage, and I wonder whether that contributed to some of the earlier lower success rates. Have a look at that very differently to the UK model, and we had 1 kit. So no matter who you were, whether you were special forces, whether you were a medic on the ground, on the helicopter, in the hospital, we had 1 standard surgical airway kit that everybody used and everybody was trained on. Everyone had at least the minimum training of battles, so battlefield advanced trauma life support, where everyone received the same hour training that they had to be assessed on using sheep sort of neck models. And it doesn't matter whether you were the junior medic or were you the senior consultant, everyone got the same initial training. So there was 1 standard of training. When you look further down on the medics on the ground, we only allow the medics to do either airway maneuvers, OP or MP. If that fails to take effect, we don't have LMAs or iGels, and we don't teach them to intubate, we then would expect them to proceed to a surgical airway. And I think this helped keep their bandwidth in a reasonable state, because they would see the airway wasn't working from simple maneuvers, and they'd been trained uniformly. They'd been empowered that they would be fully supported to make that critical decision when the time was needed, and therefore they were able to perform the procedure successfully. And I think that went a long way to supporting that. I've just got a few pictures and CT scans on here for you to just have a quick look at. So if we start off, and I'm not massively going to debate, but we can in questions if there is any. This is a horizontal incision representative of a surgical airway procedure, as opposed to what is often taught in civilian practice now is the vertical incision. Now, our data suggests this is a good way of doing it because we've had high success rates. However, caveat that with the patients had a mean age of 25, so they were fit and they didn't have a lot of subcutaneous fat tissue around the neck, and that may make landmarking a lot more difficult. So there may be differences in civilian practice. You can see the surgical airway in here, just under the, they've got the hyoid bone up here, cryothyroid membrane, and that's going straight into the trachea, and there's the 3D imagery here. Some of the surgical airways, now these are not UK imagery, this is from some of our colleagues in the US. You can see here in this case, they've started off making a reasonable effort, and they put the surgical airway on upside down, for example, and it's gone completely astray, nowhere near the trachea, which won't work successfully there. So it gives you an idea of the difference in balance of what you're looking at when you're trying to perform this procedure. So what makes it succeed? And it's not rocket science. I think military training for the guys on the ground is very much like a weapons drill to them. You know, if they're in a firefight and the weapon stops firing, they have a drill to follow, and that's almost the way they were trained with surgical airway. The first thing is set yourself up to succeed and not to fail. You must remove fear. I think we'll talk specifically paramedic practice. If there's other people who are not paramedics on the line, then obviously within your scope of practice. But when we're looking at certain procedures that we have to perform that are performed rarely, whether that be, for example, surgical airway or say a needle decompression, for example, because we're not performing them very often, instantly when we're going to have that procedure, then there's fear. And as Yoda said, you know, fear leads to anger or stress or whatever, and then fails can happen. Believe that you're going to succeed, and that's how we taught all the guys on battles, is you will succeed. You've been trained, you've had your training, look, you're getting the same training as a consultant, and it doesn't matter who you are, if you follow these landmarks, you follow this procedure, you will be successful. And by empowering individuals and making them believe they will succeed, then for me that's gold dust, and that will help. And what I call the rule of ones. So the rule of one was simple: one kit, one standard of training, one team approach. So if it was you and somebody else there, you knew exactly what the other person was going to do because you'd been trained exactly the same, and one individual belief of success. And by employing the rule of ones, I think again that led to relatively high success rates in this population. What does this mean for UK paramedic practice? Now, I put the framework wheel up there because obviously, quite rightly, the College of Paramedics do an excellent work, and we'll look at what their scope of practice is. We kind of all know now potentially what a career pathway is for us, and therefore who should be trained. Now, in the military environment, we trained all medics to do this, but I have to say that was because there was a need. There was a need to train everyone because, you know, evacuation times were long. We couldn't get resources into people, and if it was under fire, it was often very difficult to land a helicopter. So these guys needed to be able to do it. Looking at this, the civilian practice model, should all paramedics do it? Should we leave it to specialist paramedics, or should it be advanced paramedics or consultant paramedics? Now, I feel it sits somewhere around the specialist paramedic level. So it's somebody who's an experienced paramedic, who's taken further educational training, has good clinical experience. And I think that's for me, that's around about the level it's required at. And you know, when you're looking at the wagon wheel here, it's around about the green zone. Some people would say no, advanced consultant only, but then how often can you get that advanced or consultant paramedic to the scene where they might, and if all the ambulance services follow this model in the future, you know, there may be a lot more specialist paramedics around. The first question is it needed? Well, actually, it's not that common in civilian practice. We're not having, or traditionally we weren't having, these battlefield type injuries. However, we all see the news at the moment, Paris, Brussels, you know, these attacks in Belgium and France are becoming more often, and resulting in, you know, suicide vests on people's streets, gunshot wounds that you wouldn't normally see, using high velocity rounds such as AK-47s. And, you know, is the UK next on the list? And is this something we're going to see? I think if you read some of the literature around the people at the Paris incident, they talk about they were faced with what looked like battlefield war zone injuries, and they didn't all feel capable of training, and therefore there's a gap certainly in some of our major cities, you know, London, etc. Then surgical airways on a lot of the paramedics and other teams may be essential. Is it achievable? I don't think we can train every paramedic to do it. It's, you know, it's hard enough getting time off every year to do clinical training. I think most trusts have 2 days mandatory training every year. Obviously, we've got to do information governance. We've got to put out fires with our extinguishers every year. we've got to know health and safety, we've got to know how to lift the box and all the usual stuff that's mandatory. So after you take all that out, there's not a lot of time for clinical training. And so to make it for everyone is not achievable. That's why I think we need specialists at advanced level. Do we want it? Do we as a profession want to perform this skill? Now, I don't speak for the profession. I represent things at certain committees and stuff, but I think as a paramedic, we want to do always what's in the best interest of the patient. And therefore, I suspect as a larger group, we possibly do want this. But again, in the right bracket and at the right level, there's a need. HEMS and other services are not always available, and often airway compromise is presented. It's an immediate threat. It's in front of you, and you might need to take action. Certainly in a sort of multi-pronged terrorist attack where lots of things are coming in, whether it be blasts through bombs going off, then followed up by groups of people with small arms. Then I think we might not be able to get highly trained teams in there, and it might need to be at the right level. So that's kind of the thoughts on sort of levels of practice and stuff like that. So I'm going to give you a quick summary, and then I'll more than happily take some questions on this. Often I find with these sessions the main stuff comes out in the questions. So 26% survived the hospital discharge because of surgical airway intervention who otherwise may have died. And from a military perspective, that proves our need. We've discussed the civilian implications. It can be successfully performed by well-trained military combat medics and junior doctors in the most extreme environments. So how do we replicate that for civilian practice? Remember, train for success and not failure. We must get negativity out of practice, because if we believe in success, we will be more successful. Potential lessons for civilian practice, perhaps. I think there is. I think we should employ this. What technique we should fundamentally use may need a bit more discussion. And obviously, this is from an old presentation there, and I put, don't forget to log your advanced airway procedures. I think I was normally plugging the CPD and Med3 clinical skills app, which I was involved in as part of my research, which allows you to log your advanced airway skills and other things. And that's probably what that line is. If anybody hasn't got that, then I'd say clinical skills log downloaded from the Apple or the Android store. So briefly, before we go moving on to questions, I'm going to have a little bit of a plug at the moment, if you don't mind, so I do apologise. Obviously, these webinars are free, and I think they're a great resource. And I'm here tonight as part of, as in my role as, although it's military data, I'm plugging Basics Ambulance North East, which is a newly reformed basics charity. And we're after raising some money to get our charity status back. Andy Ormerod is kindly going to donate the normal fee that people would get for doing this to the charity for me. And if anybody thinks that getting a resource like this is worthwhile and wants to see more of these type of lectures, we've got a few of our guys lined up to do some more webinars for Andy. We've got one on pre-hospital ultrasound from Paul Younger, who's also the vice chair of the College of Paramedics. I've got a local consultant, emergency medicine consultant, doing one on sedation. We've got a consultant paramedic from our team going to do one on pre-hospital cardiac arrest. And if people, when they watch these presentations, feel like they can give a couple of quid, if you visit that link that you can see on the screen, it's always massively appreciated. And if I see a surge from the presentation tonight, then I can certainly jovial more of my team around to come and talk about these sort of different, more critical care issues, which if that's the kind of thing you want to see more of, then certainly that'll help me push them in the right direction. So without further ado, we've got the references there, and I'll hand it back over to Andy, and we'll start taking some questions. Thank you very much.
Hi, thank you, Andy. Yeah, excellent presentation. We have just got a question from Angela. Angela asks, are there any plans to trial this in the UK? And it will be interesting to see civilian research. Well,
Angela, surgical airways are not done in the UK, so they're done in advanced teams, and also they're being performed in my scheme. A paramedic, so on the critical care response unit, could perform a surgical airway if required. We carry in the kit. We've also got the advanced paramedics in London Ambulance Service carrying surgical airway kits, and also Andy Ormerod, who's on tonight, is a paramedic in Northwest. They're advanced paramedics and consultant paramedics are also carrying surgical airway kit. Both London and Northwest have used this procedure. The last time I heard, there was about 8 to 10 cases, and I've not heard any of them fail. but that goes to prove that when we talk about that, what level is that, these guys are getting a lot of extra time to train. So it is in UK practice at the moment. It's just not necessarily in every trust, and it's not necessarily widespread. But there is specialists, as I say, and advanced paramedics out there now doing this procedure if it's needed. It's just not needed that often.
Okay, well done. Thanks, Andy. Another question from Lee is, can you give an example of a couple of jobs when a surgical airway would be absolutely critical to the management of a patient?
So I think the obvious one for taking the really exciting trauma out of the maxillofacial trauma, that might result in a burns is another good example. Maybe if somebody's got a compromised airway, that preemptive strike potentially, but I would proceed like that and cautious. However, what I would say is the classic maybe is the choking patient who back slaps and abdominal thrusts don't work, they collapse, and then if you think about it, the procedure is, I would have a quick look with a laryngoscope, see if there's anything I can pick out. But if they've got a blocked airway, you can try and ventilate them all you want, there's no air going down. And I think in the choking patient, then it is definitely in civilian practice where we could probably save a few lives. I appreciate, again, we don't go to that many people who are choking and are completely occluded. But when we do, it's life or death situations then, no airway, and that surgical airway might just make a difference in that situation.
Okay, thank you for that, Andy. Another question from Martine is, can you stipulate what will be the minimum qualification an individual would need to hold in order to perform a surgical airway or be involved in learning, training, and then application of a surgical airway?
Well, so at the moment, say you go on a basic spec course, for example, you get taught to do a surgical airway and that, and you can do as a paramedic be taught to do it. That's not a license to practice. Anybody can teach you, and I could teach any registered professional to do a surgical airway in 60 minutes with good practice and training. I teach on the spec courses, and I've taught it on other courses. The application of the skill is not a difficult thing to teach. The license to practice never comes from a training course. That comes from your organisation, and what you need to do is provide a good governance system behind it. So rather than people just going out there doing a surgical airway and nothing being said about it, you'd need very robust governance on when and how you would perform a surgical airway, what the procedure would be afterwards. So would you write a mission debrief? Would there be a case review? And I would suggest if you're doing surgical airways, absolutely there must be. And every case would be looked at very closely to make sure it was the right decision and the procedure was performed correctly and that it was the right decision making. Because if you're doing this procedure, it's a biggie, and therefore I think very important that the governance behind that, clinical governance behind it, is very robust within your area.
Excellent, thanks, Andy. Another question from Andrew. Were any end-tidal devices used to confirm positioning, and were airways inserted using bougies?
Good question, Andrew, and I like that question. First of all, yes, end-tidal was not available to the guys on the ground, so they wouldn't have been confirmed. But then as soon as they would have gotten on a helicopter at some point, and then end-tidal would have been used immediately on board the aircraft to confirm correct placement. And that's where we got the absolute confirmation from a lot of them. The patient came on the aircraft and it was recorded that that device was providing end-tidal CO2. The bougie debate, I agree. We did not use bougies because we had a very specific military design kit, which has a rigid purple type inserter in with it. That's not the correct name of it, by the way. And therefore, bougies were never used because you wouldn't be able to use them because of the way the kit was designed. If you're using a non-standard piece of kit, for example, you're using a size 6 ET tube, then I would say, yeah, bougie seems to be the way to go. You not only, if you've got a bit of blood in the way, you've made your incision, you'll feel the cricoid rings, and I think that's the way a lot of people are teaching it now. So in civilian practice, and if you look on some of the foam sites and MCRIT and things like that, they're talking about vertical incisions, get your landmarks, make your incision, use the bougie and railroad it over the bougie. And I think that's a perfectly acceptable way of doing it as well. If I had a bougie in a size 6 tube and nothing else, would I do in a scalpel? Would I do the surgical airway? Yes, I would, and I would use a bougie.
Perfect. Thanks for that, Andy. I think that is it for all the questions. If anybody else has any more questions, then you're more than welcome to fire them through, and I'll quickly just go through some of the other up-and-coming webinars that are launching shortly. We have got a webinar on the 21st of April on fabricated or induced illness, Munchausen syndrome by proxy, the safeguarding approach. We have got another free webinar on the 27th of April, presented by the same guy, Brendan Gray, and that is on safeguarding children, the journey from referral to response. And so what Brendan's going to talk about is from the moment we as a professional make that referral, what happens next, and how does social care and social services depict what kind of response they're going to get from the information that we pass on. As Andy referred to in the presentation, Paul Younger is going to do a presentation on paramedic point of care ultrasound on the 11th of May. But what I will say is that presentation is booking up really, really quickly, and there isn't many spaces left in it. And so if you have an interest in pre-hospital ultrasound, get yourself over and register onto there. And then we've got two really useful, certainly going to be useful for my practice, on the 27th of July 2016 at 7:30. The code is hanging out, a pre-hospital guide to managing of core prolapse, by Amanda Mansfield, and she's a consultant midwife from London Ambulance Service. And again, as part of the Marmite range, maternity Marmite series, Amanda's going to talk about the feet are coming first. Pretty much my worst nightmare when it comes to maternity jobs. And so to book onto these webinars, it is really simple. You simply just go across to cpdme.com/webinar, or just Google search CPD webinar, and it will take you directly to that page. And so for those people who are members of CPD tonight, as I said, your certificate and your digital copy will go automatically into your portfolio. So when you go into your dashboard, you'll see a copy of there with the title of the webinar, the date, a copy of your certificate, and also a copy of the recording. So all that you need to do is just jump in there and reflect upon your learning experience. All that leaves me to do is to say thank you very much, Andy Thomas, for joining us tonight and talking about surgical airways.
Thank you, Andy. Much appreciated.
And if anybody has any questions, you can drop them to us at CPDMe, or indeed you can drop them onto Twitter to Andy Thomas. Thanks very much. And all that leaves me to say is good night. Thank you.